All right, we're going to talk about the approach to hematuria. And so we're going to organize this talk as if we're seeing a patient who comes in with the chief complaint of, I'm peeing blood. Now, clearly the next step is to take a really good history and physical, but in terms of lab tests you can order, the next step is to order a urinalysis and urine microscopy. So let's go through how we're going to interpret these. Okay, let's get this easy one out of the way. Let's say on history, the patient has irritative voiding symptoms, fever, dysuria, and then they're complaining of hematuria, and the urinalysis shows white blood cells, positive for leukocyte esterase, as well as pyuria, and maybe a little bit of hematuria. Okay, so this patient probably has a UTI, and so for this patient, you want to order a urine culture. I wouldn't say it's incredibly common that a patient with a severe UTI comes in complaining of peeing blood, but I suppose it's common, and especially ruling out UTI would be important. So you're going to get that from the urinalysis and the microscopy, and hopefully from the history as well. So next, let's consider a situation where the dipstick stains negative for heme, and then there are no red blood cells. And so a little side note about the dipstick. So when you're looking at a dipstick of urine, it will say blood. And so what that is actually measuring is the presence of heme. And so that portion of the dipstick is actually testing for the presence of heme. Remember, heme is porphyrin with iron present, and so it actually acts as a pseudoperoxidase. And so as it reacts with that specific part of the test strip, it will change the color. So really when that dipstick says blood, negative or 1+ or 2+ or whatever, you're really testing for the presence of heme pigment. So let's say if it's heme negative or red blood cell negative, but the urine's discolored, that would suggest the presence of something else. So here's an interesting list of things that can cause discolored urine that is heme negative and red blood cell negative. So recent ingestion of beets can cause beeturia. If a patient's ingesting phenazopyridine, this is medication used to relieve irritative voiding symptoms. This discolors urine. The patient has porphyria. Or recent use of rifampin. These can all discolor the urine, but would not cause true hematuria. Now, what if the urinalysis was positive for heme? So on the dipstick, it would say positive for blood, but then under microscopy, when you actually look, you do not see red blood cells. So the two things to consider here would be hemolysis. So basically, if there's intravascular hemolysis, this would lead to free urinary hemoglobin. So in this case, the hemoglobin in the urine is causing the reagent to change. So the dipstick will be positive for blood, but there's actually no red blood cells. And so this could happen, let's say, with a severe transfusion reaction or autoimmune hemolytic anemia. So free hemoglobin in the urine could do this. The other thing would be myoglobinuria, which you see from rhabdomyolysis. So significant muscle breakdown would cause high levels of urine myoglobin. And one thing to note when you're spinning the urine down, free hemoglobin would actually turn the supernatant discolored. So it would be sort of a pink colored or red color, whereas urinary free myoglobin would not change the color of the supernatant, so it would be clear. So even before you do your testing or look, you could have a clue about what's going on. Now finally, if the dipstick is positive for blood, positive for heme, and then also on microscopy you see red blood cells, now let's consider that. So of course, finally we now get to consider whether the patient has a true pathologic hematuria, some sort of disease that is leading to blood in the urine. But I want you to also consider other things that can cause maybe transient hematuria. Let's say if a woman is on her menstrual cycle, there may be some contamination, some blood that ends up in the urine that doesn't actually represent true hematuria. So if this happens, you could just have her retest her urine, do another urinalysis and microscopy in a number of weeks. Also, apparently, vigorous exercise right before a urinalysis or acute trauma can cause some transient hematuria that doesn't necessarily reflect pathology. In these situations, you just want to repeat the urinalysis in a number of weeks. But let's assume that now we're interested in the patient who does have true hematuria. So if we've ruled out some of the mimics, so you've considered all these other things, you've ruled out a UTI, you've ruled out some bizarre things that discolor the urine, and you've ruled out hemolysis and rhabdo, let's consider what to do about true hematuria. So when forming my differential for the patient who has true hematuria, I like to work my way anatomically from the outside in. First, for example, urethral bleeding could come from urethritis or traumatic injury to the urethra, maybe from a Foley catheter or some other procedure. So in men, the source could be coming from the prostate, so BPH could be associated with a little bit of hematuria. Prostatitis, although rare, could cause microscopic hematuria. Prostate cancer as well, but most commonly, recent trauma or procedure, let's say prostate biopsy or a traumatic Foley catheter placement could cause hematuria coming from the prostate. Next, when thinking about the bladder and causes of hematuria, malignancy comes to mind. So especially a transitional cell carcinoma or a squamous cell carcinoma can arise in the bladder. Also, acute cystitis, as we mentioned before, but obviously the patient will have pyuria and a urine culture that's positive. But there's also a non-infectious hemorrhagic cystitis that could occur either secondary to radiation. Let's say a patient was getting pelvic radiation. And also some chemotherapies, especially cyclophosphamide, is known to cause a hemorrhagic cystitis. And also schistosomiasis, which is only found in certain endemic areas, but this chronic infection can cause significant inflammation in the bladder and the ureters and anywhere really in the urinary tract, but especially in the bladder can cause essentially a hemorrhagic cystitis and hematuria. Next, when thinking about the ureter, the main things I want you to think about, first, kidney stone or nephrolithiasis. Patient has unilateral flank pain and hematuria. This should be the first thing that comes to your mind. But also malignancy can occur here. It typically is a transitional cell carcinoma. It could be, de novo arising in the ureter, or it could be from the bladder, making its way up the ureter. So these are the main things that we're looking for when we think about the ureter. So now let's consider renal causes of hematuria. So the kidney has a wide variety of sources for blood in the urine. So one obviously needs to be mentioned is malignancy of the kidney. So renal cell carcinoma or a transitional cell carcinoma that's made its way up to the kidney could cause bleeding. Cystic and structural diseases. So the ones that come to mind are polycystic kidney disease or even medullary sponge kidney. So in polycystic disease, sometimes these cysts can actually bleed internally and eventually result in gross hematuria. Also, there could be an arteriovenous malformation of the kidney. This can actually cause a AV fistula within the kidney. Shortly after a kidney biopsy, that can happen. There's also something called acute papillary necrosis. So it tends to occur in patients who are ingesting large amounts of NSAIDs, or patients with sickle cell disease can actually have papillary necrosis, and this can cause gross hematuria. It's also the syndrome called the nutcracker syndrome, where the left renal vein gets compressed between the aorta and the superior mesenteric artery, and it can actually cause some flank pain and gross hematuria. There's sort of a related syndrome called loin pain hematuria, which is sort of a rare disorder that we don't know much about, but it can cause unilateral flank pain and intermittent hematuria. Also, a hemorrhagic form of interstitial nephritis that's very severe can actually cause gross hematuria. The things that come to mind for me are some viral infections like viral interstitial nephritis. Sometimes we see in kidney transplant patients like adenovirus and even HSV. They've been reported as causing like a gross hematuria when it's actually an interstitial nephritis. But obviously, glomerular hematuria is a common cause of having hematuria as originating from the kidney, and so there's a vast differential for causes of glomerular hematuria. So let's consider that right now. So when thinking about glomerular causes of hematuria, if there's concurrent renal insufficiency or proteinuria, especially consider any cause of glomerulonephritis. And so there's going to be a whole video about glomerulonephritis available for review. So arriving at this stage, I want you to consider that differential, and we'll go through that later. But let's say that there's only isolated hematuria without proteinuria or without renal insufficiency. If you see that, you should consider at least one of these four diagnoses, because one of these four is probably present. So this may just be an early case of IgA nephropathy manifesting as isolated hematuria. It could be MPGN, which is membranoproliferative glomerulonephritis. It could be Alport syndrome, which is a hereditary nephritis, and these patients can have gross hematuria, and there's could be a positive family history of renal failure and sometimes deafness or corneal abnormalities. There's another disease called thin basement membrane disease, which is another cause of hereditary hematuria. Typically, there's a family history of microscopic hematuria and the absence of renal failure. So this is one way we think about the approach to the patient with glomerular hematuria. But at this point, we listed a very long differential. You may be wondering, how do you sort out how to approach this patient? So let's go through that now.